And next I'll invite Dr. MS Ravindra, who is going to talk on MICS in challenging cases. And by the time he will be finishing, the next speaker should be on the next podium, please. And next speaker will be Dr. Deepak Meghur.
All of you must be knowing MS Ravindra is a wonderful teacher and a wonderful surgeon.
Good afternoon, my friends and my colleagues. This is the way I do a routine cataract surgery. I take a direct incision in the anterior sclera, go across the limbus and on a virgin conjunctiva. And this is a case of microspherophakia. With very high pressure, the patient came. I've done an iridectomy there, which is not relieving the pressure. So I resorted to a surgery. How to do a rhexis in such a patient? What are the options we have? Suddenly I decided that I can hold the capsule with two instruments. On the left side with an MBR blade, on the right side with a cystitome I made punctures, otherwise it's impossible to puncture this anterior capsule which is released from the zonules. Now with the rhexis forceps I can hold the anterior capsule, and like a handle holding the bag, I call it as a bag holding bag handle technique. I'm doing a rhexis and I could support the entire lens in spite of the very lax zonules, and I could complete the rhexis. What next now? If I remove the cortex and put the lens in the bag, it's going to dislocate at some point of time. So normally I would have removed the cortex and I would have removed the capsule, did a vitrectomy, and then I would have put a PC lens supported by the iris. But here suddenly at one point of time I thought, why not retain the posterior capsule? So I'll avoid the damage to the zonules and ciliary body by tractions, and the entire capsular bag is present, and in front of it I put a iris claw lens and enclaved it behind the iris. This is a very unique technique. For the first time it's reported in the literature. I have not reported, but the first time I hunted the literature, it's not there anywhere, so I could do it. So what happens, this case, does the PC pacify later? I've been doing this for last 4 years now, and all these pieces are clear magically. I do not know how. Maybe there's a concept which makes the PC clear. And here again, as you can see here, when I did the rhexis, there was a lot of zonulopathy, and here again this is going to dislocate. You can see the lot of IFIS there. I've removed the cortex, and again I've done the entries on the side. I can't put a PC lens here because it's going to get dislocated later. So the same concept I've utilized for a patient for an eye where zonulopathy is extensive, which I detected accidentally during the surgery. This was not diagnosed preoperatively. So you can see the rhexis margin there. Obviously it is sitting. And the lens is supported posteriorly by the posterior capsule, and anteriorly it's held by this. It will never get dislocated. This is a classic case of, it looks like, posterior capsular cataract, and we should be very careful in such patients, otherwise you will have a rent in the posterior capsule during the surgery. The MSICS being a very low pressure, low flow technique, I'm not bowing or pressing the posterior capsule backwards. This is probably the ideal technique for any presumably posterior capsular cataract. So now you can see you should be very careful. Anterior chamber is very shallow, it's not deep, and I'm not pushing because the pressure in the entire eye is atmospheric or less than atmospheric right now. I could put a lens, and without any problem I could have completed the surgery. So this is one good indication for MSICS where you suspect posterior capsule to be dehiscent or potentially weaker. This is again a case where a Morgagnian type of a cataract, as it was explained by Dr. Amesha just now. The trypan blue staining will help you in doing a good rhexis. It will stabilize the texture of the anterior capsule, I have enlarged with a 5.2 blade. I completed it. All of you are familiar with this technique of doing rexis or double rexis or a spiral rexis. So then I went and completed the rexis in that patient. What I am trying to tell is, it is so safe. I can predict that I can get a good rexis even in this patient all the time without any runoff or an Argentine flag, because of a technique called tunnel floor entry technique. When I deepen the chamber, enter while doing the rexis, enter through the floor of the tunnel, and then I finish the rexis. That's what I did in this patient. It's a very hard cataract, fibrous cataract, and then I could cut the nucleus into two pieces with continuous irrigation of visco in front of it using a cystitome. I don't have any special gadgets for that. Remove the entire cataract, remove the cortex, and then the patient had opted for a multifocal lens, and I have no hesitation in putting a lens of multifocal nature even in such mature cataracts. I was told that many people refuse to or hesitate to put the... This is one technique where I slit the top of the cartridge of all cartridges, so that the lens goes inside beautifully without any pressure on it. See, the lens immediately after putting, you don't see the crease that you get on the lens. So that's my presentation. If there are any questions, I would answer it. The idea of it is the technique of SICS is a low pressure technique where throughout the surgery you're not increasing the pressure. It's got too many advantages. The second is flow of fluid is only about 30, 40, 50 ml. You can finish the entire surgery with that amount of BSS. Third thing is, it's a very simple surgery, but then it needs as much attention, as much training as a good phacosurgeon. Don't think that it's a very easy surgery, but then it is not a step to learn phacosurgery. It's an end by itself. Thank you.
Thank you, Dr. Ravindran. And